I thank the organizers for allowing me to fill up for Ramanjit. I'll be going over the highlights of clinical trials in the context of progression. One must remember that these trials have been conducted under certain test criteria. So they do not apply completely and they do not saturate the subject. So we have to take guidelines from these. I'll also be going over some of the Indian studies and then see what take-home message we can extract out of this comparison. So talking first of all about the ocular hypertension study, a large study where the conversion to glaucoma with treatment was reduced to 4.4 as against the non-treatment arm, that is 9.5% conversion to glaucoma. The risk factors that were highlighted in this study were the older age group, higher CD ratio at presentation, higher PST and low CCT. So these are the collateral benefits of this study. The perimetric progression in India, this is an in-house data of RP Center, where they have found progression of 11% in POAG cases and 15% in angle closure cases. It's not only the progression in terms of fields. The inter-visit IOP fluctuation as already highlighted by the previous speakers. So any change more than 2 millimeter is on number of visits equivalent to 3 or more is associated with progression. So these are the surrogate markers that we should be on the lookout for in cases of impending progression. The early manifest glaucoma trial, medical treatment versus observation for 6 years initially. A large number of patients again, no target IOP was set, but a mean follow of 25% was obtained. And each millimeter was computed to add to a risk of 10%, add or subtract as the case may be. So extended reports from the study reported a 67% progression in 8 years, and progression was reduced to half if treatment was instituted. Going further, the risk factors they highlighted with the older age group, higher baseline damage, exfoliation syndrome, and higher IOP. Treatment had its own problems of increasing the lenticular changes. Now, the collaborative initial glaucoma treatment study where medical management versus study was initiated in a large number of patients. It was found the IOP reduction was slightly more in the surgical group. A very low IOP, more than 38% was set. Cataracts and local complaints were more in the surgical group, and progression was comparable at 10.7 to 13.5% medical versus surgical. Coming back to the unanswerable question, does it justify primary surgery in developing countries? So should we put all our patients under the knife or should we do medical treatment? That's the unanswered question still. Severe glaucoma in India, again an in-house study of RP Center. Perimetric deterioration in 43% cases. Half of these deepened and 1/3 had expansion of the field defect. Median time to detection by 10-2 versus 30-2 was 36 and 49 months. But the important thing is none of the patients realized that they were going through a change. And the correlation, a positive correlation was drawn with the IOP fluctuation and a longer follow-up. Okay, I'll been asked to conclude, so I'll conclude with the last 2 slides. The aim of management in glaucoma is to target IOP, set a target IOP with minimum fluctuations, iridotomy in angle closure glaucomas. And in summary, the take-home message is, please evaluate and re-evaluate medical therapy. Socioeconomic and education status has to be kept in mind, and trabeculectomy should not be shied away from if required. Thank you.